There we go. Okay, I want to welcome everyone to the third session of our mini conference, Celiac Disease Hidden in Plain Sight. We've titled this one, You Want Me to Do What? Because we're talking about the issues that surround the diagnosis of celiac disease. And so first, I want to introduce you to our group of speakers today. First, we have Isabel Hujoel, which I probably didn't do that right, but here we go, who is, it's Dr. Hujoel. She's a gastroenterologist at the University of Washington Medical Center, and she's a clinical assistant professor of medicine in the Division of Gastroenterology. And she has done some research while she was at the Mayo Clinic, which she just recently left to join the University of Washington, that is related to negative results of the celiac disease blood test, or the blood test for celiac disease. We also have Dr. Hilary Jericho, who is a pediatric gastroenterologist and assistant professor of pediatrics at the University of Chicago Comer Children's Hospital, where she has developed a video capsule endoscopy program that has interest in the realm of celiac disease diagnosis, particularly amongst the patient community. And then we also have Maria Luci, who is the assistant director of digital media at Beyond Celiac, but today she's wearing a slightly different hat. And that hat is as someone who has been through the process of celiac disease diagnosis. And she will tell you a little bit about what her experience has been. So the reason that we're talking about diagnosis today is that it can be problematic for people. It doesn't seem to be as straight and uncomplicated a process as we wish that it was. And the complications run the gamut from not being able to be diagnosed using the testing that is currently recommended and accepted, to the other end, which is going on the gluten-free diet before you are tested and diagnosed, and then your diagnosis becomes somewhat impossible unless you agree to go through a gluten challenge, which many in the community are reluctant to do, primarily because they probably were sick and they don't want to get sick again. That seems to be the area where that's the biggest issue. So we see frustrations with negative test results, the invasive nature of the endoscopy, the inability to be diagnosed if you're already on the diet, without having to go through a prolonged gluten challenge. So the group of people that we've gathered today have either done work in their field or have some experience that addresses some of these issues as we look at the current state and the future of diagnosis of celiac disease. So first, we're going to have Maria tell us what her story was in terms of her journey through the process of celiac disease testing.
Thanks, Amy. I would just add one more thing to the barriers or issues with celiac disease. First is that we hear about the subjective nature of the biopsy reading through pathology, that like one pathologist might give a score, a Marsh 1 score, and another pathologist will say, oh no, it's actually a Marsh 3, or, you know, getting the biopsy from the right locations, which is another issue that we've come across or heard from our community. So yeah, I will tell what I like to call my undiagnosis story. We hear a lot, we're always at Beyond Celiac asking people to share their diagnosis stories. And then we also hear a lot of frustration on being diagnosed and a lot of people who aren't actually officially diagnosed with celiac disease. So, about 5 years ago, I began experiencing a lot of gastrointestinal distress. I was not feeling well. I went to my doctor. She did a bunch of tests. She said my thyroid's slowing down. That might be the cause of it. That was the only thing she could come across with the test she did. I did some research. My family has a strong history of autoimmune diseases. I come across Hashimoto's disease. I asked her, I saw some people saying that they felt better on a gluten-free diet. I asked her, do you recommend this? She said, oh, there's no harm, just go gluten-free. Just try it. I had not been tested for celiac disease. Didn't really know about celiac disease at this time. So I went gluten-free for a few months. I started feeling better. And then about, I don't know, 6 months later, I go to a wedding and I eat bread. I got very ill after that. I had diarrhea for over 2 weeks. I go back to my doctor. I start losing a lot of weight. I lost 10 pounds. I had at this point went back to eating gluten-free because I thought, oh, this happened because of this. I had all sorts of tests, including for parasites, all sorts of not fun testing done. I couldn't eat anything. If I ate anything that wasn't like super plain chicken, rice, and baby food, then I was just sick all day. So all my tests came back negative. At that point, she says, well, your celiac test came back negative, but you've been gluten-free except for this one instance. So I can't tell you definitively or not. At this point, I make an appointment with an endocrinologist to see about the thyroid, but they're so busy that I couldn't get an appointment for many months ahead. I stay gluten-free. I have very, very slowly can start eating food again, but it takes me a long time. I finally make it to my endocrinologist. I find out that I'm pregnant. And so she says, I don't think you have Hashimoto's. I think you have celiac disease, but you can't do this gluten challenge now because you're pregnant. So she does some more tests. She says you're severely vitamin D deficient, like almost a 0 vitamin D. So they immediately put me on vitamin D, some other vitamins. And she says, live like you have celiac disease until after you're done breastfeeding. So many, many months later, about 9 months after my daughter was born, I'm still living like I have celiac disease, but having to explain anytime I go to the doctor or whatever. At the hospital, I actually had a bad experience where they had no food available for me. And it wasn't on my chart because it's not an official test. So I finally ended up working at Beyond Celiac when my daughter was at 9 months old. They explained to me the importance of getting tested and going through with everything. So I see a local gastroenterologist who is recommended, and he gives me the genetic tests, and lo and behold, it comes back negative. So he diagnosed me with non-celiac gluten sensitivity, which after all of this, like many years, it's just been very frustrating experience. And I still don't really know what happened, if I actually do have non-celiac gluten sensitivity or not. I don't have celiac disease, and it's just been a very frustrating and long journey that I know a lot of other people in our community experience very similar outcomes.
And I'm sure that that's the reaction that you will get. And Isabel can probably talk a little bit when she does her thing about that negative test result and what it could mean or not mean, depending on how you want to look at it. But first, I will have Hilary talk a bit about, so she has established a video capsule endoscopy program at the University of Chicago. And so, Hilary, if you want to tell us a little bit about that work, especially how it would relate to celiac disease and how it might be used in the future. We do know that currently, in order to be diagnosed with celiac disease, you have to have the positive blood tests, you have to be consuming a gluten-free diet, and you have to show, I'm sorry, the gluten-containing diet. Oops. You have to show some level of intestinal damage via an endoscopy and a biopsy. So that's where we are right now, but we're trying to look a little bit into the future. So I'll kick it off for you, Hilary. If you can tell us first what video capsule endoscopy is for anyone who doesn't know, and then what you've been doing in that area.
Absolutely. Thank you so much, Amy and Maria, for having me today. It's an honor to be here. So as Amy said, my name is Hilary Jericho. I'm a pediatric gastroenterologist at the University of Chicago Medicine, specifically at Comer Children's Hospital. I've had a long-standing history in both endoscopy and celiac disease. I'm part of the Celiac Center here at the University of Chicago. I'm also the co-director of endoscopy, pediatric endoscopy. In 2014, I started the video capsule endoscopy program here at Comer Children's Hospital. I had my training across the city at Northwestern at Lurie Children's Hospital, where I'd had initial exposure to the use of video capsule. And so when I came down to the University of Chicago after my fellowship graduation, I felt it was a really important part of the GI practice and in diagnosis of a number of different disease entities. And I received the funding to start the program here at the University of Chicago. So for anybody who's not aware of video capsule endoscopy, it literally is a capsule that a person swallows, or if they're not able to swallow it, it's placed endoscopically. There's a number of different capsules now that have a number of different capabilities. The main one I have interest in, it's by Medtronic, it's called the SB3 Pill Cam. And if I had to describe the size to people, it's kind of about the size of a fish oil capsule. So I used to say, you know, we always like to use helpful, comforting adjectives. And I used to say, oh, it's a little capsule. And then I came to realize, okay, that's not a good adjective because it is a little bit on the bigger side. It's about the size of a fish oil capsule. But I work specifically in pediatrics, and amazingly, from what I've heard from patients, I don't swallow it myself. It goes down rather easily. It doesn't have a taste or stickiness to it like pills do. So it does go down easily, but it's about the size of a fish oil capsule. And again, you can swallow it or place it endoscopically. Once it's in the GI system, it will take roughly 60,000 pictures of the small bowel, which amounts to an 8-hour video. I do watch these videos a little bit quicker, so it takes me about 30 to 45 minutes to actually review the images. But it's an overall non-invasive way to investigate the entire small bowel. So kind of merging my two worlds of celiac disease and endoscopy, last year I did apply for a grant to investigate the use of video capsule in the diagnosis of celiac disease in children. It's been looked at quite a bit in adults, and it's been found to be a very useful tool in the diagnosis of celiac disease. At this point in time, it is not a tool that can replace endoscopy per se, but it's a great adjunct to endoscopy. While most patients with celiac disease, the portion of the gut that's affected is the very first part called the duodenum, which is reachable with endoscopy. There are infrequent cases where the celiac disease may not affect the duodenum and may affect the bowel farther down, such as the second part called the jejunum or even the ileum. It doesn't happen a lot, but it is a possibility. So really the thought behind the video capsule is that in these patients that, for example, may have symptoms and may have the labs suggestive of celiac disease, but they undergo endoscopy and the biopsies actually come back negative, you know, it could be a great adjunct tool in these individuals to look beyond the duodenum to see if there's the standard gross findings such as the scalloping or the mosaic pattern that we see that's classic for that gross appearance of celiac disease farther down in the gut to support that. In those situations, if there's enough there, that may be enough to make the diagnosis on its own. If there's not, it gives you information that maybe the patient needs a deeper enteroscopy called a double balloon enteroscopy to reach that portion of the bowel to grab those biopsies to confirm the diagnosis. So it is something that we are in the process of starting the research to investigate the use of video capsule in children. The other advantage to video capsules, there are some patients that may be at very high risk for undergoing anesthesia. And in these patients, again, while it is not as confirmatory as a biopsy would be in the diagnosis of celiac disease, it at least gives you another piece of that puzzle, another piece of information to help suggest that, yes, this patient has celiac disease and it's a safer modality than undergoing anesthesia to help with that diagnosis when an endoscopy may not be an option for certain individuals. So the thing about the video capsule is if someone has advanced enough celiac disease that you can see those findings with the naked eye, it is an exceptionally good tool. It's got very good what we call sensitivity and specificity for the diagnosis of celiac disease. That being said, if people have more mild cases, oftentimes, even when we go in for endoscopy, the lining may actually still look normal, but when you grab those biopsies to look under the microscope, that's when you get that confirmation that it really is celiac disease. So in those situations, the video capsule wouldn't be as useful as a tool because it is going to detect a normal appearance and miss that those findings are at the microscopic level. But it definitely can be an amazing adjunct tool to the endoscopy, and it's already been shown to have very good sensitivity and specificity for the diagnosis of celiac disease in adults. So my goals are now to investigate that in children and see if it's an equally effective tool in the diagnosis of celiac disease in children.
Okay, so I think that that can lead us, and we'll come back to each of our speakers and we'll have a 3 or 4 way conversation. But I think in a certain way, it sort of sets things up for Isabel to talk about what she's doing, because you will most likely not get to a point where someone's going to be interested in, or your physician won't be interested in further investigation of whether or not you have celiac disease unless you have a positive TTG blood test for celiac disease. That's usually the first hurdle or the first step, whichever way you want to look at it. And so, Isabel, if you want to tell us a bit about the work that you've done in that area. And one of the things I think that your study said about the blood test for celiac disease, the TTG blood test, and when it's negative, not when it's positive, but only when it's negative, is that it might not be any more accurate than a flip of a coin. And that really stuck with me. And probably with people who have negative results of a celiac disease blood test, but still feel like something's wrong and this might ultimately be the answer. So I'll let you explain what you've been up to.
Thank you, and thanks so much for having me. So the project that Amy's talking about was specifically looking at IGA-TTG, which is the recommended serology to screen for celiac disease currently. And the reason it's recommended is that it has this very good sensitivity, or so we think. That means that if the test comes back negative, we think rest assured that that person most likely does not have celiac disease. So what I did in this study is I went back and I looked at the original studies that looked at the accuracy of IGA-TTG as a diagnostic test. And when I was looking at these original studies, what I saw is that the way that they were designed had the potential to introduce a bias when they were estimating the sensitivity and specificity. And the way that happened was, when they were doing their original studies, they were testing people who either already they knew had celiac disease, or they were testing specific subgroups who were carefully selected to be tested for IGA-TTG. By non-randomly selecting these people that they're originally testing, they introduced something called verification bias. And what that means is that when they're estimating the sensitivity, it becomes falsely elevated. So what I did is I actually went back to those original studies and I adjusted for that kind of introduced bias, and I recalculated in a way sensitivity if these studies would have been designed in a way to avoid verification bias. And what that led to was finding that this recalculated estimate of the sensitivity of IGA-TTG was actually closer to 50%, meaning that if it was negative, maybe the person has celiac disease, maybe they don't, but it's really, as you mentioned, we know better than a flip of a coin. That being said, that sensitivity of roughly 50% is a recalculated sensitivity. So it's me going back and kind of recalculating what they would have gotten in their original studies using specific equations that have been developed. So it's really an estimate. We won't really know what the true sensitivity of IGA-TTG is unless a study that's designed to avoid that bias is performed. And there are a few out there, and their estimates that they have for sensitivity are closer to 60 to 70%. So still not great, not as great as we think it is, which is, it's often quoted as having a sensitivity of about 93% or higher. So, and what that means is that when you get a test for IGA-TTG with your doctor and it comes back as negative, we maybe shouldn't take it as being such a cut and dry, no, you don't have celiac disease as we do now. Particularly if we have a high suspicion for celiac disease. I personally think that we need to do additional blood marker tests, or even talk about going ahead and doing that upper endoscopy or a capsule endoscopy to kind of look into that a little bit further.
Ironically, this year, my mother-in-law was diagnosed with celiac disease. And really one of the reasons she was diagnosed is because I kept pressuring her to get tested. She seemingly out of nowhere was incredibly anemic and needed emergency transfusions and was in the hospital, and then continued to need, like, even after the transfusion, more transfusions. And her doctors kept saying, no, you don't have any GI symptoms, so it can't be that. So they insisted on doing every other test in the book and found no bleeding, found no other issues that could be related to anemia. And I said, you have to get the endoscopy, you have to get the blood tests. So she did get the endoscopy, and they, and then that's where some of the subjectivity comes in. Her GI was like, well, we saw the lymphocytes, we saw this and that, but we're not 100% sure it's celiac disease. But we're going to diagnose you with it anyway. And she's been on the gluten-free diet now for, I guess, about 6 months, and she does not have the anemia anymore. And but other people in our family are like, well, your doctor was unsure, so really, do you need to be that careful, and this and that? So there's more in the air of people trying to make her think maybe you don't have celiac disease. And then I'm just like, oh, no, please continue to eat gluten-free. I don't want you to end up in the hospital again with the severe anemia. So the capsule endoscopy would have been great, because we would have gotten more of a picture, and maybe somebody else could have looked at it and given their second opinion. But
so I'm happy to chime in at this point. It sounds to me that she had a very convincing case for celiac disease, elevated celiac serologies, the clinical findings, and then even if it was just MARSH1 and increased intraepithelial lymphocytes, or if it was MARSH2 or 3 and there was mild villus blunting, in my mind, that sounds like a pretty clear-cut picture for celiac disease, and then if there is any uncertainty or ambiguity, when the patient goes on that gluten-free diet, because again, it sounds like a very convincing story in my mind that she really does have celiac disease. If then all of her blood markers improve and all of her symptoms go away and the celiac serologies are coming down, again, I think that's very telling that it was an accurate diagnosis. If you really, really want to double check it, you could repeat the endoscopy. And if the gut's completely healed now and the only intervention was going gluten-free, again, I think that's a very strong case that the diagnosis of celiac disease was real. I wanted to come back to Isabelle's topic of the TTG IgA. I know there's some variation in the adult and pediatric world on the antibodies that are sent. And oftentimes in children, there's a second antibody called a deamidated gliadin peptide, not to be mistaken with the old school anti-gliadin antibody, but it's a deamidated gliadin antibody, specifically the IgG antibody as opposed to the IgA, which has been shown actually to be fairly good at kids in accurately diagnosing celiac disease. I don't think it's used as readily in the adult population, but if you look at studies, the interesting thing about the deamidated gliadin peptide in studies where people were ultimately diagnosed with celiac disease and they had stored blood samples leading up to that diagnosis that they were able to go back to, it appears that DGP IgG turns positive prior to the TTG IgA. And so, the question's always, is it worth it to send it as a screening lab off the bat? The flip of that coin is that it can be prone to false positives. And that's why there isn't a clear-cut definitive answer. And what I mean by that is that while that DGP IgG sometimes will come back positive in isolation, the TTG is normal, but that DGP is positive, it can pick up cases of celiac disease that would be otherwise missed. but actually more often than not, it may lead to unnecessary scopes and is falsely positive when someone doesn't have celiac disease. So the question is always, is it worth it to send these multiple antibodies at the start? Are you going to pick up enough patients that it's worth it to counterbalance the patients you're going to, scope in an unnecessary way? And so I do wonder with of these cases where the patient, had a negative TTG and then was found to have celiac disease, were those one of the patients that maybe just had that deamidated gliadin peptide IgG, and that's why the antibodies didn't look consistent with celiac from the start. So, it's again one of those dilemmas in the diagnosis of should it be part of the standard antibodies that are sent, or should it not? And it is a big question out there, and most of the guidelines actually lean against it, like not sending it, because again, it will lead to unnecessary endoscopy in a subset of patients. But it is always that question of, picking up those extra few, how does that weigh in that balance? And I don't know if Isabel wants to touch more upon that as well.
Yeah, I guess what I was wondering when you were talking, I was thinking, well, maybe that plus like a capsule would be a good way to exclude people who to not go through with a subsequent endoscopy if the capsule is normal. But yeah, I mean, I think it's a great point. I think my take on it is if someone's coming in with symptoms that are pretty significant, impacting their quality of life, if your suspicion for celiac disease is high, if they have a family history, if they have severe iron deficiency, if they have these kind of signs and symptoms that we classically associate with celiac disease, I think in those cases it makes sense to add on additional serology. However, for kind of the general screening, maybe when the suspicion of celiac disease is low, it makes less sense to do that. And then you're going to be subjecting more people to unnecessary procedures. So I think that it needs to be maybe a more careful thought process than just having it off the bat being there. And maybe I think one of the questions we're going to get to is, this idea of using kind of a matrix of questions, signs, symptoms to decide who to test for celiac disease. It might be interesting to kind of combine, history, family history, signs, symptoms to help determine which serology to potentially do, as well as opposed to having just a one serology for everybody. Anyway, it's an interesting point.
Mm-hmm.
And then
I'm sorry, go ahead, Hilary.
Oh, the only other point I wanted to come back to with regard to Maria's story, and I think we all hope so much at this point in our medical advancements that most people know, physicians know before having patients go on the gluten-free diet that all that testing should be complete. Because I think, unfortunately, the situation Maria got into is a situation a lot of patients get into, that they're told, well, go ahead and try the gluten-free diet, see how things go. But inevitably, if someone feels dramatically better off of gluten, the idea of having to go back on gluten to get that definitive diagnosis is obviously not something people want to do. It's not a pleasant experience. So, I think constantly working to educate people in the medical profession that if you have concerns for celiac, please get all the testing done first, so we get as much information as we can to best guide the patient, really is the way to go. And I think continuing to work to educate everyone so people are aware of the steps in that diagnosis and making sure it's done correctly. So, patients don't unfortunately wind up in the situation that Maria did, that, she went off of gluten, felt great, but then didn't have that answer she needed. And so I think the key is programs like this, getting the word out, educating people to work towards getting all these things done correctly the first time around.
So I wondered if both of you can give us an overview of what your thoughts would be on the continuing low rate of diagnosis of celiac disease. At Beyond Celiac, we often talk about how it's been a long time during which the diagnosis rate has been reported as low. Now, we hear numbers that are all over the place. Some places report that 83% of people who have celiac disease are undiagnosed. Other places report that, well, now it's up to 50% of people who have celiac disease are undiagnosed. And so I guess what I'm wondering is, do you have any thoughts on why that is? with the standards that we have in place to diagnose people and the fact that those have not changed in a long time, are there relationships between the two? And what are your overall thoughts on the what we would call the low rate of diagnosis, wherever it is, of people who have celiac disease? And Isabel, you want to go first?
Sure, yeah. I mean, I feel like I see quite a lot of people. I mean, so we're a little bit biased in the gastroenterology field because we see people who've already kind of undergone an initial workup for a lot of their GI symptoms before they get sent to see us. A lot of the people that I see have been tested for celiac disease. So I feel like I see a lot of testing, but that being said, I mean, there's a lot of people out there who don't get tested, obviously, based on the research that we're seeing. What I'm really interested in is, who are those people that are undiagnosed? Do they have symptoms? Are they asymptomatic? And what I'm really curious about, and what I'd like to kind of look at going forward, is how much would they benefit from being picked up? Because there's a way to find everybody with celiac disease, which is to screen everybody for celiac disease. But at this point, we just don't have the evidence to support that, to support testing everybody for celiac disease, because we don't know that everyone's going to benefit from that diagnosis. So I think some of the things we need to do as we move forward is to find out who benefits from diagnosis. Is it everybody, in which case we should test everybody and figure that out? Or is it a select group of people? So who are these people that we haven't picked up yet? And are they people that are going to really benefit from being picked up? And that's kind of one of the big questions, I think, for celiac disease moving forward, is that exact question. So I guess I'm kind of turning your question a little bit to the other side, which is, should those people be picked up and diagnosed? Because the gluten-free diet, Maria, as you probably know, is not easy to follow necessarily. It's a pretty big change in your lifestyle for your family and yourself. And there's a little bit of social stigma about it sometimes too. So especially maybe, Hilary, as you could say, for children too, I would imagine a gluten-free diet is not necessarily an easy thing to do. And so I just think we need to kind of think about who these people are that aren't being diagnosed, and should we really find them and change their life so dramatically? And it very well could be that we need to do that, but I think we need to find that out first.
And so it sounds to me like when you say maybe there are some people whom it is not that important or who wouldn't benefit that much by being diagnosed, you mean someone who has celiac disease, is asymptomatic and is not suffering from the intestinal damage, because sometimes you can be asymptomatic and have the intestinal damage. But you're, Isabel, talking about that very specific person who technically, if I can use that word, and maybe I can't, has celiac disease, but isn't suffering as a result of it. Am I following what you're saying? Okay.
Yeah,
and Hilary, it looks like, like you have thoughts on this too.
I definitely do. And, from a pediatric perspective, I think I see an interesting subset of adults that are associated. So, standard diagnosis, once a patient gets the formal diagnosis of celiac disease, technically all first-degree relatives should be screened as well, because they are very high risk. While celiac disease only affects roughly 1% of the population, roughly 15% of first-degree relatives. So that's of the person affected, the parents, the siblings, and their children. Their risk is up to 15%. So, the recommendation is typically that all first-degree relatives at the time of a person's diagnosis should also be screened. That can include just the antibodies, if that's all the family wants, or I typically will recommend, if insurance will cover it, or if the people have the monetary funds to cover the cost of it, getting the genetics as well. And like Maria said before, the genetics can be very, very helpful to rule people out. It doesn't rule people in. So, the numbers all over the board, but I tend to quote roughly 30 to 40% of the world have the genes for celiac disease. Only 1% of them go on to develop celiac disease. So just because you have the genes doesn't mean you're going to develop celiac. It just means you have the capability of it. But if you don't have the genes, we generally think you are not capable of developing celiac disease without those. So I will typically recommend to first-degree relatives to get the genes tested. If they're negative, the likelihood that they're going to develop celiac disease is exceptionally low, and they don't need to go on to have ongoing screening moving forward unless they became symptomatic. Then I might recommend recommend it. If they have the genes and they don't have active celiac disease right at that time, then we do recommend, at least in the pediatric world, once every couple of years, having those screening labs repeated. And I have a number of patients who the siblings had negative genes at the start, negative antibodies. And then even though they didn't have symptoms, a few years later got screened again, and suddenly the antibodies are going up. Most of the time we do recommend getting the endoscopy, and then they have confirmed disease. And I think, I might play a little bit devil's advocate to Isabel's comment that not everybody benefits from it. I think a lot of people out there are asymptomatic, but unfortunately the harm is happening. And even if they aren't having the gastrointestinal symptoms, there can be serious consequences. I know actually a number of people now in the adult world, some personal, some related to children I've diagnosed with celiac disease that had quote unquote, no symptoms, no GI symptoms, were completely unaware that they might have celiac disease. And in one case, the person actually, it resulted in a pretty significant bone fracture, which again, set up all the red flags to get the testing done. And then it turned out this person had very bad celiac disease that had been underdiagnosed and had severe thinning of their bones. And then the other person was a relative of a patient of mine who had celiac disease. And again, at first questioned why they needed to be screened because they had no symptoms, and then they were screened, their celiac antibodies were quite elevated, saw their primary care physician, and had blood testing done for calcium, vitamin D levels, and had imaging done of the bones to look at the density, and it turned out they had significant thinning of their bones too. Luckily, it hadn't gotten to the point of a fracture, but again, a lot of that damage may be happening below the surface, but can have very significant consequences down the road. So, I think even if people don't have the obvious GI symptoms, most of the time, if they truly have active celiac disease and the damage to the gut has occurred and they're having malabsorption of nutrients, I think that in itself can be a serious problem down the road. And it is the reason that we do recommend, even if you are quote unquote asymptomatic, that you should go on the gluten-free diet to prevent those things. The other part of that, and this has been also studied, is that so many of those people that think they are asymptomatic actually have a lot more symptoms than they realize. And I've had a number of patients who were patients of a parent that got diagnosed. The children got screened, they had the positive antibodies. They told me they had no symptoms. We did the scope, they got diagnosed, they went on the gluten-free diet, and when I saw them follow up, the children were shocked. Oh my goodness, I was tired all the time. I just thought it was the standard adolescent. I'm working too hard at school, doing too many things, but suddenly I have all this energy, or I had these headaches all the time. I just thought they were headaches, and all these things have gone away now. So I think even those people who think they're asymptomatic oftentimes have a lot more symptoms than they recognize. The one last thing I just wanted to talk about underdiagnosing celiac is I think a part of the problem too is, do people want to be found? So I definitely have a subset of parents of my patients, and the child has celiac, and I recommend that they get screened. And oftentimes it's one parent. I don't want to put dads down. I'm a mother as well. My husband's an amazing person, but I do find a lot of the times the moms will go get screened, and the dad may have some GI symptoms, and the mom screens negative, but she's like, I just can't convince dad to go. He just doesn't want to. He says he's fine. It goes the other way too. But some people, they're happy with the way things are, and they don't want to be found. And, it's unfortunate because I think improving people's health, if they really have celiac, and preventing those more significant consequences down the line is in the person's best interest. But sometimes, people don't want to be found. So kind of the flip side of that coin.
We've definitely
Probably
seen
everyone,
that.
who has celiac disease in their family knows of people who would rather not find out.
Yes, exactly.
Well, I just
Which
wanted
is-
to throw in a plug because you guys made me think about a current grant that Beyond Celiac is funding, looking into. It's Dr. Stahl at Colorado School of Medicine. She did a screening study called the ASK study of children and found actually a pretty high prevalence. It was about 1.6% after they got, not every kid that screened positive went back for the endoscopy, but of the kids that did screen positive, it ended up being 1.6%. So we are funding further study into the quality of life of these children that had no idea and wouldn't have been tested otherwise, to see what that is, to help push, research forward into looking at screening and overall if that's worth it. Because as you guys know, the US Preventative Task Force doesn't currently recommend screening, and that's when insurance covers and what a lot of doctors will look at. So, but they say they need more research. So this is, part of that, moving that forward.
So I guess if I was thinking that on the flip side of that would be the person who does get the negative blood test, and after getting the negative blood test is told they can't have celiac disease, and yet oftentimes will go on the gluten-free diet anyway. Isabel, in terms of someone who gets a negative test result, if the reliability of the negative test is not as high as perhaps we have always thought it was, what should that person do? What would you tell them to do with a negative test result?
Yeah, so I mean, if they have a high concern for having celiac disease, I mean, it's a tough situation to be in if your provider isn't wanting to move forward with testing. I mean, you have to try, I guess, to be your own advocate there and kind of see if they'd be willing to order additional serologic tests, or even an upper endoscopy or a capsule. And if that provider isn't, then it's a matter potentially of even switching to another provider who's willing to kind of work with you to look into it a little bit further. But it's a tough situation to be in if your provider is not willing to move forward despite a negative test. And I think there needs to be a little bit more. First of all, we need a little bit more data on IGA-TTG as a test, more studies that are done, adjusting for this potential bias. And then if that continues to show that IGA-TTG is not as good as we necessarily think it is, then we need to come up, with guidelines that recommend a different test, so that we aren't stuck in this situation where we have this test that may not work as well as we think it does, but yet that we're telling people to check for celiac disease with first.
And do you think that some of the undiagnosed celiac, the people who have celiac disease who are undiagnosed, could they be falling into that category of someone who had a negative blood test and so now will never be captured, if you want to use that word, because they're going to live the rest of their life thinking, well, I don't have celiac disease. Maybe Maria, to a certain degree, falls into this category. Okay, I have non-celiac gluten sensitivity, so I'm going to follow the gluten-free diet anyway because I feel better. But from a larger perspective of who has celiac disease and who is counted, could we be losing some people who should be counted and who want to be counted because they've got an incorrect negative? I know no test is perfect. That I should preface all of this. They're always, a test that the results are not 100%, but because we rely on this, I'm just wondering if we're missing a certain percentage of the population because of the incorrect negative test.
I think it's certainly possible. I was thinking that as I was listening to Maria telling about that study on the children. That being said, so, I think IGA-TTG, the sensitivity does depend, my understanding is, on the age of the person that it's done in. And so, in children, we can sometimes go on a very, very positive IGA-TTG and not do a biopsy to make a diagnosis of celiac disease. We don't have that yet in adults, but the other thing is that our current idea that IGA-TTG is 93% sensitive, that's based on studies done in children, done in adults, done in asymptomatic, done in symptomatic. It's done in a whole range of people where really that test performs very differently in those different groups. And that's another big flaw of our understanding of IGA-TTG, is that we're basing it on kind of a conglomerate of many different groups of people where it might perform very differently. But yes, I think that we could potentially be missing people by using it as a screening test in studies where we're trying to find the prevalence of celiac disease.
Mm-hmm, mm-hmm, mm-hmm.
And I think
okay, well, so go ahead. I'm sorry, Hilary.
Say one additional thing. I mean, if you have a patient that just had that TTG IgA screening test, and there's a high enough suspicion. I think just because one test comes back negative shouldn't negate everything else. And I know, at least in my practice, if a patient has a high enough suspicion, I'll send the other antibodies, because the more antibodies you add on, the higher the large amount of information and the higher accuracy you're going to gain. So, you know, if the TTG IgA is negative and I really have a strong suspicion, I'll send the DGP IgG and the EMA IgA. And the EMA IgA is thought to be, I mean, it's the most expensive and it's the test that requires the most expertise, because it actually requires a person to run that test. But it's one of the best tests you can get. And so, you know, if there's enough suspicion there, I'll send the other tests, and I'll normally send the genetics too, just to have the most information, have the most complete picture for that individual. And I think the one other thing to remember is, just because tests came back negative once doesn't mean they're going to continue to come back negative. I know 2 people personally, and I have 1 patient over the last few years that were negative the first time around. Their symptoms didn't get better. The following year got repeat testing, and suddenly everything came back positive. So, you know, there's always that possibility that you just tested too early and you missed it. So, you know, just because there's a one-time negative doesn't mean the rest of that person's life they can't have celiac. Things change. So just always keeping that in mind too.
Yeah, that's a good reminder. We're not convinced that people are very good at that kind of follow-up, but it is a good reminder. I think so. What I'll do now is I will, I know that the people who have expressed interest in the mini conference have sent us in lots of questions. So I'll start to go over these. Some of them we've already touched on a little bit, but maybe by asking something new will emerge. And if you feel like we've already answered the question, you know, we can move on past it. But someone was, you know, fairly to the point, and what they wanted to know is, will the invasive intestinal biopsy ever be eliminated from the diagnosis of celiac disease, in your opinion?
I'm happy to jump in first. Gosh. At this exact point in time, I really think it's the best confirmation for celiac. Like Isabel was saying, we do have in the pediatric world a set of what are called ESPGHAN guidelines. They're European-based guidelines in pediatric gastroenterology that in a subset of patients, if they meet certain lab parameters, you can feel with almost 100% certainty that they will have active celiac disease on a scope. And what those parameters require is that their TTG IgA level is greater than 10 times normal. We don't put an absolute value on that because there's a lot of platforms that run that antibody that have different upper limits of normal. So to capture all of them, it's defined as greater than 10 times upper limit of normal and a positive endomysial antibody IgA. If they meet those criteria, it used to include genetics as well, it used to include symptoms as well. Now those aren't absolute requirements. You can feel with near 100% certainty that that patient will have active celiac disease on endoscopy. And if the families elect in that subset of patients, you can forego on the biopsy. That being said, I've learned in medicine that there almost always seems to be an exception to the rule. And for that reason, I still feel most confident having that biopsy confirmation. So if I had my way, I would always recommend it to have that absolute diagnosis. But in that subset of patients, you can get away with the lab parameters on their own to feel near 100% confident that that patient is going to have active celiac disease, and the biopsy and the endoscopy, you can forego on them if you want to in that subset of patients.
Okay. I don't know, Isabel, if you want to add anything or...
Well, I agree with what Hilary was saying. I mean, and in a lot of and again, in adults, we're much more likely to do procedures than in children. There's a little bit of a lower threshold, but a lot of the times the symptoms that prompt the testing for celiac disease, an upper endoscopy is going to be down the line to look into those symptoms. So if it's not celiac disease, there might be something else. I mean, there's several other diseases that can involve the small intestine that look like celiac disease, and that can cause similar symptoms that we won't find without an upper endoscopy. So I have a hard time seeing the upper endoscopy not being done just for that purpose. If it's not celiac disease, then what is it? And so anyway, I just wanted to add that to there.
Okay. So someone else asked, why is there not a standard procedure such as 5 or more biopsies in specific locations that are sent to a lab that specializes in how to study and report them uniformly? How do you know when your results are being sent to a pathologist who knows what to look for and report it? And how do you know before the procedure if your doctor truly knows how to diagnose celiac disease? There are a lot of questions in there. You take them one at a time, I suppose.
Yeah, that's a tough question. I mean, so there are guidelines on kind of recommending how many biopsies to take, where to take them. And there's been a lot of studies on this to look to see, you know, what's going to be the most accurate way to go about this. The guidelines even give recommendations on how the pathology should be reported. But as the question's getting at, a lot of centers don't follow those guidelines, and the pathologists don't follow those guidelines. And I think, you know, I think certainly going to a celiac center like Hilary's at is a helpful way to know that they've worked with pathologists. The endoscopists are aware of how to go about doing that according to the guidelines. You know, how to make sure your physician knows is a tough one, aside from, gosh, maybe be asking them. That's not there's no real delicate way to go about that though. So it's a tough question. I don't know if Hilary, maybe you have a better insight into that.
I mean, it is always hard knowing from searching the internet, like who has all the inside knowledge and the latest scoop on celiac disease and knows the guidelines and knows exactly how to do things. Like Isabel said, there are set guidelines, and typically the recommendation to make sure to capture celiac is getting at least 4 biopsies in the second part of the duodenum, at least 2 in the bulb. Typically the recommendation is grabbing those one at a time so they don't get crushed together and they can be the most properly oriented under the microscope to look at. And then the key is, you know, if there are areas of the gut that look affected, you want to try to grab those areas. The problem with celiac disease is it is a patchy disease. It doesn't occur diffusely and continuously. There are affected areas scattered between areas that aren't affected. So that is always the problem, and why you can miss it is because of that patchy nature of it. So again, if you're going to a center, like Isabel said, that has a celiac center, most likely they probably are in the know and have the latest information and hopefully are able to follow guidelines and do things properly. But it can be difficult to understand who has that knowledge and who doesn't. I guess the key is researching that individual well, researching the center well, you know, turning to resources like Beyond Celiac Disease for guidance on helping you find the people that may be best in helping you to make that diagnosis.
And I think the other thing, so it's, if you're going under a procedure, I think it's fully within the right of you, the person going under that procedure, to ask the endoscopist, you know, how do you plan to test for celiac disease during my procedure? How many biopsies are you going to take? That's perfectly in your rights. You're the one undergoing the invasive procedure and getting those biopsies done. And so again, I mean, and maybe it shouldn't be this way, but being your own advocate, I think, would be very helpful in those situations too, and very reasonable questions to ask the proceduralist.
I think that kind of patient empowerment would be important. You know, I think sometimes we're reluctant to ask our general practitioner questions, and then you get into a situation where you're dealing with someone you only are ever going to see this one time, and you have no history with them, and you know, you just figure you're going to go in and they'll do what they'll do, and you'll get out. So I think that is a good bit of advice for people who have done enough of their homework to know that these are the things that this person, this specialist should be looking for. I think our next question takes us a little bit into a slightly different area, and that is the issues that people have with the gluten challenge when they've gone on the gluten-free diet, sometimes just out of desperation to feel well. But this question is, are there diagnosis methods coming soon that would allow for a diagnosis without doing a gluten challenge? Then they said, doing a gluten challenge for me is not worth the nerve pain and the migraine from the nerve pain and migraine perspective. So can you share with us what you know about those possibilities?
So I can jump in a little bit here. So, I mean, at this point in clinical practice, to my knowledge, the only thing we really have in those situations, again, in clinical practice, is the genetic testing. And there again, it's only really useful if you test negative, then we know the likelihood that you have celiac disease is exceptionally low, as Hilary was saying. Now, there are methods in the research field that are out there, just not yet kind of in clinical practice, that do have the potential to either maybe skip a gluten challenge or have a very limited gluten challenge. So for instance, there's the HLA-DQ gluten tetramer that's in clinical research, and then you don't need a gluten challenge to look for those. It's at this point not in clinical practice. I think its cost might be a prohibitive aspect there. And then there's cytokines that there's been some studies looking at where people will get a very short exposure to gluten. And then they can test your blood a couple hours after that exposure, look to see what those cytokines are doing. IL-2 is one of those cytokines. And they found that in people with celiac disease, just that very brief gluten exposure, you see those cytokines go up. And one important point there is that in people with gluten sensitivity, so not celiac disease, you don't see those cytokines going up. So again, that's not yet in clinical practice, but it is in the research field and getting actively looked into. And again, I think cost is going to be a little bit prohibitive there. And also kind of making sure that we know how sensitive those tests are, and specific.
And Hilary, what are your thoughts?
I mean, I don't think I have a whole lot more to add beyond what Isabel said. I guess the only thing that I would think about with the gluten challenge, the couple things I would add in is, you don't need a lot to trigger someone with celiac disease. It's technically believed that 50 milligrams or more of gluten exposure per day is enough to activate the disease if you have it. That being said, to give you an idea of what that means, one slice of regular bread, it typically has somewhere between 1,500 to 2,000 milligrams in it. So I think that's the other thing to understand. And when I have patients do gluten challenge, to let them know they don't have to eat huge amounts of gluten all day long. I mean, I think the average American diet has about 17 grams per day of gluten in it, when again, 50 milligrams is enough to cause a problem, which is drastically less than that. So, I do let families know all they really need is a couple of regular crackers a day is more than enough to get that enough gluten to cause the reaction. And then we also know that the gut is affected typically quicker than your blood testing will become abnormal, and the gut heals quicker than the blood testing will normalize. So, it is believed that if someone's on that gluten for at least 3 or 4 weeks, you can do an endoscopy and typically find the findings that you're looking for. While if we're waiting for the blood testing, oftentimes we lean closer to 8 to 12 weeks. So there are some options in there. If people can handle a small amount of gluten, that might be enough that they don't feel terrible, but you get the information you need. So just knowing kind of also how to do that gluten challenge, and what the options are, and being well educated about that, because I think a lot of people think they have to eat 3 large pasta meals a day to get the information you need, and that is not what's necessary.
So I guess what you're talking about is that in someone's mind, the gluten challenge may be more extensive and more intolerable than they may think. So we have so many things to talk about, and we could talk and talk and talk, and I've lost all track of time. So Maria tells me that we have about run out. So I thought that what I would do is give each of you a chance, if you have any concluding thoughts, briefly on what what the future looks like, where people can pin their most, maybe hope is the wrong word, maybe it's the right word, looking into the future of diagnosis. So think of it as kind of a conclusion, and then I'll give you both our heartfelt thanks, because I think it's been such an interesting conversation. So anyway, Isabel, you want to go first?
Sure. I mean, I think that, I think there are going to be changes in terms of diagnosis and how it's done. And I think that part of that is going to be what serologic tests we do and how many of them. And I do think that I would be very interested in a future where how we test is kind of individualized based on history, symptoms, associated conditions, where it's more individualized as opposed to kind of one recommendation for everybody. That would be something that I'd like to see. And I think that endoscopy is going to stay a big part of diagnosis, but I think we are going to get more and more these helpful kind of tests that we can add on. And again, individualized diagnosis for certain people based on their preferences. For instance, using capsule endoscopy, like Hilary knows a lot about. So I think there's that. And I think the gluten challenge, I think we all know it's a very, very, very difficult thing for a lot of people to go through. And I think there's a lot of research going into that area right now to try to avoid doing a gluten challenge. I don't think there's anything available at this point clinically, but I wouldn't be surprised if we saw something become available, just given how big of a need that is in clinic. So
I think what you're actually doing is answering a question that I didn't ask, which was about whether diagnosis would be easier if there was kind of a matrix that coupled antibody testing and resolution of symptoms and the gluten-free diet. So in your answer, you answered a question that I didn't ask. So thank you for that. And Hilary, what are your thoughts?
I mean, I think I second a lot of what Isabel says. I think we are working very, very hard to come up with alternatives to endoscopy. We're not there now, but alternate blood tests, looking again, like she had said before, cytokine levels, new and improved antibodies, things along those lines to, again, help find an alternative to endoscopy that's just as good. And again, we're not there yet. We have a lot of adjuncts that are very good, but not as perfect as endoscopy is. So, you know, I think we're working on it. We're trying to get there, just like we're trying to find the cure. And hopefully one day in the not too distant future, we will be there. So, you know, taking the baby steps little by little and always working to educate and let everybody know as these things surface and become available to patients.
Right. And I think, like I said, the conversation that we've had today, I think makes me hopeful, because I realize that with people like yourselves thinking about these things and questioning and pushing for some change, that that's gonna get us speed up our baby steps a little bit more. So I want to extend to you a very big thank you, a big Beyond Celiac thank you. And Maria, I don't know if you want to say anything in closing, but it's been our pleasure to have this time with you this afternoon.
Yeah, I'll just say, yes, thank you both. This was a really exciting conversation. And to anybody watching, you know, advocate for yourself. And if you still have symptoms or if you're unsure, like keep going and try to figure out and find someone who will listen to you. So.
Okay, well, thanks. And with that, not only do we conclude our session, but we conclude the entire mini conference. So thanks to all of our participants.